So I suppose a bit of a history of childbirth is key to understanding because it has shaped the service we currently provide. And really history is punctuated by the regulation and training of midwives and doctors, efforts to tackle maternal deaths, the move of birth from home to hospital, medical dominance and patriarchy, and the rise of consumer groups. And we are really now at a time when we know that in the midwifery profession and the wider structure of maternity care is a matter for popular and political debate. So, in 1902, this saw the introduction of the Midwives Act, and this really then ultimately saw the decline of the unregulated and untrained handywoman, but really at this point in time it made very little difference to the care experienced by women. And in 1930s, really, the high rate of maternal deaths had been unchanged in the previous 50 years, despite salaried midwives and hospital services increasing. And in 1936, the Midwives Act brought about the creation of community midwifery and antenatal and postnatal care. And of course, the birth of the National Health Service in 1946 saw free access to health care and increased standards of living for women. And really this period was characterised as a high point for community midwifery in particular, with women cared for midwives they knew, and midwives having the satisfaction of providing that full range of care of maternity care to their women. And this is really nicely depicted in the Call the Midwife popular TV show that you will see. But as completed family size began to fall, there was also a sense that some women wanted at least something different from their experience of maternity care, and that it should be an end in itself rather than just a necessary hurdle on the path to motherhood. So the following 20 years saw the triumph of the argument for hospital birth over home birth, with the debate focused on the health of the fetus following its discovery through ultrasound scanning techniques. And this time saw the explosion of the belief in scientific birth and ensuing technology. And here we have three lovely ladies in labour in their medical spacesuits in 1965 in an attempt to ease the pain of childbirth and raise the intelligence of their offspring. A suction pump was attached to the chair to lower the pressure, and a gauge just controlled the pressure gauge. I mean, it didn't work, obviously. But the 1990s was really a period when the tone of the wider social debate around childbirth changed dramatically. So changing childbirth, with its 3 C's, choice, control and continuity of care and carer, has been credited with the catalysing debate around care in pregnancy and during birth, and even revolutionising the language used to frame it. The impact of changing childbirth and home birth, or choice of place of birth, was probably ultimately more symbolic than real. But it did restore midwives to what they saw as their rightful place in the hierarchy of maternity care by making it explicit that they were the guardians of normality. So the continued development in the plurality of voices through National Childbirth Trust and active birth movements sought to campaign for a change in midwifery. The development of midwifery-led care, renewed support for home birth, and a growing emphasis on the public health role of the midwife saw a quickening pace in the development of midwifery itself. And by about 2002, ideas about choice and control in maternity were central to policies and protocols from ward level to national government. Women-centred care, in which the care offered was based on rigorously assessed evidence, was the only acceptable style of provision, with women and professionals expected to be equal partners in their decision-making. So that brings us up to today, and our practice today is of course driven by strategy, and you'll recognise some of the lovely documents and reports that we work towards. And of course, we have been directed and led by our maternity strategy for Northern Ireland 2012 to 2018, so that has just recently expired. So the maternity strategy acknowledged that in the context in which midwives work is complex. Our lifestyle is creating an epidemic of obesity, diabetes and heart disease, and many women now start their families later in life. So this means that some women need more specialised care, but on the other hand, we also know that in certain instances we are using too many complex interventions. And this chimes with the global perspective of maternity care, and I know Catherine has alluded to this as well. So there's 2 extreme situations exist on the continuum of maternal health globally: too little too late and too much too soon. So too little too late is care without adequate resources, below evidence-based standards, or care withheld or unavailable until too late to help. Too little too late is associated with high maternal mortality and morbidity, and is ascribed to low-income and middle-income countries where the social and health inequities mean these extremes coexist in many countries. Too much too soon describes the routine over-medicalisation of normal pregnancy and birth. And too much too soon includes unnecessary use of non-evidence-based interventions, as well as use of interventions that can be life-saving when used appropriately, but harmful when applied routinely or overused. Too much too soon can cause harm and increases health costs, and often concentrates disrespect and abuse. And it's typically ascribed to high-income countries such as our own. However, globally, midwives are recognised for their potential to contribute to population health. And the World Health Organization Meeting Report 2016 states that when midwives are educated to international standards, when midwifery includes provision of family planning, it could avert more than 80% of all maternal deaths, stillbirths and neonatal deaths. It also states that midwifery care improves 50 other health-related outcomes, including sexual reproductive health, immunisation, breastfeeding, to name a few. And in the State of the World Midwifery Report 2014, which is due to be updated, the expert calculated the scaling up the skilled midwifery workforce could prevent close to 2/3 of all maternal and newborn deaths, saving millions of lives every year. So midwives are by far the best value option for delivering high-quality maternal and newborn care, offering a 16-fold return on investment. So I think it's very, very powerful. So we note globally it's time to address the stark underinvestment in midwifery education to transform the quality of maternal and newborn health. So the strategy, back to the local and regional perspective, the aim of the strategy was to address that too much too soon dilemma and provide better care for all women. And it was about better information for women and a real true partnership with women and midwives. It was about increasing that choice of place of birth, so home birth alongside midwifery units and freestanding midwifery units. It was about midwife being the first point of contact for pregnant women and being the lead professional for women at low risk of complications, providing an element of continuity of care. About consultant obstetricians being the lead for women with complex pregnancy and promoting the physiological processes of birth and reducing variation in interventions and practice. And it was about ensuring those early public health and preconceptual messages were part of our role. So to support the outworkings of the strategy, a number of important regional policies were developed. So the success of the midwifery-led units has been clearly demonstrated and highly evaluated, and the rise of home births in the region is testament to providing choice for women regarding place of birth. So one of our best innovations in recent maternity care is the maternity handheld records, or fondly known as the green notes. And this ensures women are partners in their care as they carry their own records and have full access to the content. And indeed, we encourage women to write in them, and all members of the multidisciplinary team who provide direct care to the woman and baby should record in the regional maternity handheld record to provide a chronology of the pregnancy journey. They are regularly updated and reflect best learning and evidence. And the objectives are to facilitate coordination and continuity, to improve fetal, maternal and neonatal surveillance, to promote safe and effective evidence-based care, to provide appropriate and adequate information, to avoid duplication of information, to empower the woman to be partners in her care, and to promote an excellence in record keeping. So another recent success story of today's practice in midwifery is the Getting Ready for Baby programme, which has been implemented regionally and continues to scale and spread. And this is part of the Early Intervention and Transformational Programme. So it is based on a social model of care and combines antenatal group education with antenatal clinical care. It uses a solihull approach in an attempt to promote good interparent relationships with their unborn baby and so positively impact on perinatal and infant mental health using principles of containment, reciprocity and behaviour management. So the antenatal programme provides that real social opportunity for expecting parents, and indeed many women continue that social network and support into second, third and fourth pregnancies and beyond. And it improves continuity of care from the same midwives who are delivering important health messages, and also better engagement from fathers and opportunities for the midwives and families to all work together. But today's practice is also driven by safety and learning from various reports. And to that end, the Maternity Collaborative was one of the first regional safety collaboratives in Northern Ireland and has produced a number of extremely important innovations to improve our safety systems. This collaborative has helped to unify the 5 trusts, which at a time did work in silos, and this has helped to reduce variations in practice. So we know safety is focus, but is it really driven by the people we claim to care for? So we of course need to listen to what our women are telling us, and our women are telling us that a healthy baby is not all that matters. Women and their experience and their partners matter too, their partner's experience. They say there's a lack of respect, dignity and ownership of their body, their pregnancy and their birth. And there's inadequate information to allow for true informed consent, and that their emotional needs are not being met. So that is definitely a challenge to us. So there's a new narrative in childbirth, and it's a grassroots movement, and we need to reevaluate our language used in maternity services. So things like failed induction, failure to progress, delivering a baby. Women are not vessels, they don't deliver anything. They birth their babies and midwives support them to do this. Midwives don't want any woman to feel that she has failed to do anything or her body has failed to do anything. The birth of a baby is a huge achievement, and all women should feel incredibly proud of themselves, irrespective of mode of birth, type of drug in labour, whatever. And women should not feel disempowered or become a patient when entering a maternity unit. So as midwives, the challenge to us is to ensure we respect and trust women's choices whilst providing that unbiased risk-benefit discussion around preferences for birth. So on to the future of midwifery. So the future of midwifery lies in our hands and in the hands of future midwives. And we are delighted to now have our future midwife standards for proficiencies and pre-registration programmes. And the key themes reflect much of what I've said in the presentation. So it's about enabling and advocating for human rights for women and babies. It's about developing, critiquing and using the best evidence, about midwives taking responsibility for ongoing learning and development, and ensuring they enable and advocate for the needs, views, preferences and decisions of women and their families. Midwives need to understand local context and connect with the local communities, and they need to work across a continuum of care, and that is the antenatal, interpartum and postnatal areas. So that enables them to provide continuity of care and carer. And really the evidence for continuity of care is compelling. So women who receive continuity of care, and that is whereby the woman knows either the midwife or a team of midwives have looked after her right throughout the pregnancy, in through labour and birth, and into the postnatal field, are 16% less likely to lose their baby, 19% less likely to lose their baby before 24 weeks, 24% less likely to experience preterm birth, 15% less likely to have regional analgesia or epidurals, 10% less likely to have an instrumental birth, 16% less likely to have an episiotomy, 5% more likely to have a spontaneous vaginal birth. And there's no differences in caesarean births and no differences identified in adverse outcomes. So it is truly compelling. Further themes then of future midwives. So while I spoke previously about the strategy talked about low and high risk women and categorising the two, and midwives looking after low risk women, consultants looking after high risk women, what we know is that all women need a midwife and some need additional care too. So it's about every woman having a midwife, and she will coordinate care, and if there's additional needs for complexities, then she is the one to link in with multi-agencies and the interdisciplinary teams. So it's about midwives optimising normal processes, even for those complex women. And it's about anticipating, preventing and responding to complications and working to mitigate health and social inequalities, continuing to care for physical, psychological, cultural, social and spiritual factors, and of course taking that real lead role in public health promotion and protection, which is so important. So while nursing has annexes, the midwifery has 6 interrelated domains in the future midwife. So it's about being an accountable, autonomous professional midwife, safe and effective midwifery care, promoting and providing continuity of care and carer. It's about universal care for all women and newborn infants and additional care for women and newborn infants with complications. It's about promoting excellence, the midwife as a colleague, scholar and leader, and the midwife as a skilled practitioner. So, in conclusion, this is an exciting future for midwifery. And in this, the year of the nurse and midwife, we are delighted to have Alana, who spoke previously, on our Global Leadership Programme from the Northern Trust. And we have 3 midwives on the Nightingale Programme, some of whom are here today, and we're very proud of them. And they're doing great work. So we are delighted and eagerly anticipate a new maternity strategy, and Minister Swan has made a commitment to that going forward. So we will await that, and we know within that there will likely be transformative change for maternity services with new models of maternity care, such as getting ready for baby and continuity of care, as I described. So we really truly need to work in partnership with women and families and listen to their voices to ensure their needs are met. And to do all this, we really need strong midwifery leadership. And Charlotte alluded to it earlier on. There is a dearth of leadership in midwifery. So we need to align ourselves with the RCM Leadership Manifesto, which calls for more specialist midwives to ensure those complex women get the right care and the right pathways. We need a consultant midwife in every trust. We have 2 in the region, and I'm very fortunate in the Northern Trust that I work alongside Shona Hamilton, who's our consultant midwife, and that combination of a head of midwifery and consultant midwife is a very strong force to bring forward maternity services. We need to have a director of midwifery, and we need to have a chief midwifery officer in every country in the UK. So thank you very much.